Russell, I know that there's a new national physical activity plan that's giving prescriptions to parents and children on how to exercise. I'm wondering what that involves in terms of beyond the recommendation, how parents, do parents really have to be an integral part of getting their children to exercise? Is it enough just to tell them what to do, or do they have to know how to do it?
Thank you for that question. I think of a child's physical activity as being influenced by the social and physical environment that he or she moves through all day. And clearly the home setting is one of the places that exerts a very heavy influence on a child's physical activity. I think the schools have a critical role to play. I think they can do better. I want to, at some point, I hope, have the chance to come back to Madeline's earlier comments about her physical education experience, because I don't doubt that that's an accurate description of her experience. Doesn't have to be that way. Schools do better and can do better and should do better. But I don't believe we're going to solve these problems if we don't learn how to influence the home environment and parenting behavior. And in my field, physical activity promotion, we've learned a lot about how to do this in the school setting. We've learned something about how to do it through healthcare delivery. We had the VERB campaign and learned something about how to do it through the mass media. We've learned some about how to do it through the community environment. We have not yet had much success in coming at that issue from a public health perspective, attempting to aiming to change the home environment and parental behavior. We've had counseling studies, very intensive interventions that have successfully changed parenting behavior and have reduced sedentary time and increased physical activity in kids. But that's not a public health solution to the problem. And we have got to learn, I think, how we can operate from a public health perspective to positively influence parenting behavior so that physical activity in kids and other health behaviors, for that matter, that play out in the home environment can be beneficially influenced. So in a lot of ways, I think that's one of the public health holy grails right now, is to try to figure out how we can mount public health interventions that will successfully influence home environments and parenting behavior.
Mm-hmm. And Madeline, I was going to actually ask you in terms of what you see in schools. Gym is always seen as that chore, but I'm wondering, are there things that you've seen in your school beyond the formal sports teams that turn kids on to exercise or healthy eating? Have you seen any kind of, a lot of times we say, well, a lot of parents say, I don't want the government telling me what my child should be eating or what they should be doing during the day. But have you seen things that are presented in such a way that kids actually want to get more exercise or want to eat better?
Definitely. I know that there are a few clubs at our school. One of them that just got started was they have a running club that meets that's not a part of the track team. And they just let anybody who wants to come along. They run together. They run into groups for safety reasons, and they run into groups for support reasons. And it's inspiring to see them pull together, not as a team, but just as students who want to live a healthier lifestyle and get outside and exercise. And it's good to see that they can just do that just because they want to, and they're allowed to do that.
Joanne, I don't know if you've covered this area in your reporting at all, but in terms of parents talking to their kids about obesity, about healthy eating, there's this fear that, if you talk about it in the wrong way, you're going to turn them on to an eating disorder. Looking at the government and looking at how doctors are screening BMIs or schools are even doing that as well, and parents are getting notes sent home saying your child is overweight, and suddenly there's all this panic. Is there a way to successfully navigate this, or is it just one of those things that's going to go along with trying to deal with the obesity epidemic?
I haven't reported on any kind of statistics on, how many schools are screening for BMI or things like that. So I can't answer it in that sense. What I have seen and what I've paid attention to, and it was partly after reading one book that really made me think a little differently, is I think schools have to become aware, and it's not just schools, our whole culture has to become aware of the way that the social norms have changed, and that we have food and bad food around us all the time. And I think that you can't tell a school. I mean, it wouldn't go over very well if you tell a school that, no one can ever have a birthday snack or, But there's some of that in the legislation. I mean, there is a push legislatively to have better, healthier food and better cafeteria food and more vegetables and fewer soda machines. And some of that is in the bill that was signed a couple of weeks ago, I forgot exactly what it's called, but it's the Michelle Obama. Healthy kids food, whatever. Someone may remember the name of it. But I think that there's sort of, I've paid attention to sort of how our food environment, even for sort of, aware people, is so different. And I've seen it. I remember one example, and I wrote, if you Google my name and Oreos, this will come up. When I was in college, we had 3 meals in a cafeteria, and most of us slept through the first one, right? And then we had snacks at night. We went out at night. We went out and we didn't eat great at night. Or since I was in the college newspaper, for me, night was sort of early in the morning. But, I went back and for a reunion right after having read David Kessler's book about overeating, and that's what really made me really see the world around me differently. And one thing I noticed is that classroom buildings, the newer classroom buildings, now have cafeterias and snack bars in them. So you don't have to go to class, go back to the dorm or the eating hall, and go back to class. The food is everywhere, and the food was real. And there was salad and soup, and it was really expensive. I bought the salad and soup. But not only was there pizza and French fries, there was something called macaroni and cheese pizza. And that's what it sounded like. And that became macaroni and cheese on top of the pizza, under that, whatever that light is called. And that became, really emblematic of where we are. Macaroni and cheese pizza, to me, sort of said it all. Macaroni and cheese pizza available maybe not 24/7, but maybe, from 6 a.m. to midnight in a classroom building, sort of, to me, became this, icon of why we have fat children. And so it really, there are things that the government can do. There are things that schools can do. There are things that doctors can do. And then we really just have to rethink about why there's junk everywhere. And so much junk, there's so much. You go to a sports event, you go to your kid's sporting event, and they get junk food afterwards or during it. I mean, there's something, maybe you're not going to be able to give them baby carrots during their soccer game, but do you really have to give them donuts? I mean, it just, so yes, you have to worry about, particularly I think mothers of daughters, worry about if I come down too hard on the no sugar, am I going to make my child or my daughter totally crazy? And we have that worry about that backslide. And I don't know if we have enough data yet on, maybe one of the doctors here or nurses can talk about that more than I can, about the danger of overemphasizing, of never giving your kid a donut. And do you end up with an eating disorder and other kinds of unhealthy? So,
Dr. Jensen, maybe you want to comment on that as a psychiatrist. Sort of what does, I mean, there's so many different causes of what pushes somebody over into an eating disorder, but in terms of talking about obesity with children and talking about it in the right way?
Well, we don't have any data that suggests that parental warnings or healthy habits or encouraging healthy lifestyles is related at all to things like binge eating disorders or anorexia. I think the great risk is really that we're not having the right messages, or not having the right climate in the home that encourages the healthy behaviors. So I think the risk is all on the other side, that we're not taking that real seriously and thinking about, golly, my child's obesity, or if he goes this direction, is going to shorten his life by a decade. No parent would ever, when confronted with that, I mean, that's so, I mean, we wouldn't want our kids exposed to secondhand smoke or smoking or other things. We'd say, when you take that really seriously. So I think it's quite clear from a number of other more public health approaches for things like substance use. There are effective programs out there that mobilize a school and a community and parents, all part of kind of a public health mandate, to drive down rates of substance use. Certainly we can drive up rates of healthy eating. But it's going to have to be, I think Dr. Rios pointed out, this kind of built into the fabric of all the places that these children move through as a part of their life.
So there's no macaroni pizza anywhere they go.
Yeah, I mean, if we don't let drug pushers close to our campus, how about pushers of people that, shorten kids' lifestyles? That, I mean, it's just, I mean, we're in a free society. So, but still, when we're going to take this really seriously, that's why we don't advertise for certain things on TV, because we think it has a public, whether it be cigarettes or alcohol, we think it has public health impacts.
Mm-hmm. And with regards to cigarettes, and something that keeps coming up again and again is, look how effective we were with the campaign against smoking. Look how we've really stigmatized smoking in such a way. It's hard to actually find a place to smoke these days. And Bernadette, I'm just wondering if you've seen in your experience, are there ways to actually change the overall environment? I mean, should we sort of stigmatize obesity in a way to say, look, this is not an acceptable cultural norm?
I think you bring up a good point about the smoking issue. We need to learn from what works and use what works. Right now, there's a saying in our medical and nursing professions, and that it takes about 17 years to translate evidence from research into real-world practice settings to improve outcomes. If research ever gets translated into clinical practice, and I do think we know in many instances what works. We have the evidence to back it up, and now we've got to overcome barriers to be able to translate what works based on good scientific evidence into clinical practice. But there's multiple barriers that exist in our system, and even with clinicians. I serve on the United States Preventive Services Task Force right now. We put out gold standard recommendations, evidence-based recommendations for clinical practice, such as all children between the ages of 12 and 18 should be screened in primary care practices for depression. But there's a proviso there, and the proviso in the recommendation reads, when systems are in place to deal with depression. So it comes back to this issue of not enough providers, not enough reimbursement. As a dually prepared nurse practitioner, too, we need to educate more dually prepared nurse practitioners that are family and adult and pediatric nurse practitioners and psychiatric nurse practitioners. Because if we put those dually prepared people in primary care and school-based healthcare settings, there's going to be no lapse in referral time. Right now, we have children waiting 3, 4, 5 months to get psychiatric evaluations. If you have dually prepared providers out there, it's going to be seamless and in a setting that is not stigmatized.
Mm-hmm. Dr. Rhee, what has the government shown? I mean, clearly you say this is a complex issue. Are there specific things that the government says, these things will clearly work if we can implement them?
So there are. There was just a reference to the ARC Preventive Task Force, so that those guidelines, those clinical guidelines, are generally delivered in a primary care or a clinical setting, and so there is evidence that shows, as referenced, that BMI and counseling, for example, or depression screening is relevant and appropriate if the systems are in place. So, but we do know also in clinical settings that generally clinicians basically about 50% of the time do kind of those things that they sort of, if you ask them on a test, they would say, yes, we were supposed to do that, but do they do them in real world practice? It's very challenging, and I think that's very multifactorial. It's not necessarily they don't understand. I think part of it is that they want the education, they need to know how to do it, but I think it's also sometimes they don't have the resources to do it. There also is the CDC Community Guide, which looks at more community-based interventions, and there is a decent chapters on physical activity, nutrition, mental health, and obesity prevention. And so what you see in a lot of these things is that, multi-component interventions, because this issue is multifactorial, are really required. I want to refer to, I think within my framework of the government, there's a lot of really, cool initiatives that are going on where we're really trying to think very transsectorally. And I use my reference of networks because there is research that shows that, like Christakis' research, like constellations in the sky, that people lose weight, gain weight, smoke or stop smoking like constellations in their social networks. And so the point of bringing this up is I love this concept because when I think about that 15-minute visit, I'm like, wait, I'm potentially affecting a whole social network. If I can try to change this dynamic, or maybe this person can then, with his or her friends, try to change something. So it changes your paradigm a little bit more. And I bring it up because in those social networks, the trusting relationships, if you ever watch TED, I mean, I love that, 15 minutes and you try to learn something, and they talk about these networks. Trust is very important, the speed of trust. If you think of Stephen Covey, who talks about habits, his son wrote The Speed of Trust. Trust is so important. So who are the people you need to affect to be the leaders? We talk about schools, teachers. We talk about clinical settings, doctors or nurse practitioners. We have to think about peers. I mean, clearly we're talking about that. Peers, peer educators. I think community health workers is another great potential interventions, promotorists. Faith-based communities, the White House initiative. I mean, I've seen initiatives where we've gone to a church and gotten the pastor engaged on an issue, and then all of a sudden we get all these people coming to us, who never were seen before. So I think we have to think about that speed of trust, the role of social networks, and also creatively looking at that. And at the government level, when I see the National Prevention Plan, which is going to come out in March, you've got Department of Education, Department of Transportation. You've got all these departments that generally have not been talking kind of as much on health at the table, which is, to me, fascinating to see because the dynamics and the language is much different, but we're trying to get to a common goal.
And I think it's all a question as well as funding. Mm-hmm. Where is the funding going to come from? Every time there's a new plan issued, who's going to be funding it? How is it going to happen in the recession? Where's the money going to come from?
And this, to me, is so important in this time frame, and because I've seen it in a community health center setting. The average cost per patient that we serve is about $600 per patient per year to provide basic preventive primary care and behavioral health access and oral health access. That is a huge discount, I have to say, and there's huge success in terms of the quality metrics. So I think in this time, in this frame, what we're trying to do is what can we do with what we already have and change what we're doing a little bit so that we're doing it better. So because I agree with you, there are times in which the solution is you need more resources, but there are times in which we have to think about how we use the resources we have a little differently.
Mm-hmm.
Yeah.
And maybe, Russell, this is a question for you. We're going to open it up to questions from the audience in a minute, but just I keep hearing about having to change the infrastructure of certain communities to get people, to make it easier to walk, putting in sidewalks. One community uses walking school buses to actually pick the kids up, and the parents walk with the kids to school as a school bus, which I think is great. Have you seen specific things that have been sort of these small successes in different areas that you think could be replicated nationally?
There are successes. There are many of them. I think you can think of attacking these issues in different ways, and I think one of them is to think about specific initiatives and interventions that we can implement that will individually and collectively have an impact on the behaviors and ultimately the outcomes that we're shooting for. I think another way to think of it is at the broader level of changing social norms. And I'll have to tell you that when we first sat down to conceptualize the National Physical Activity Plan, we looked at ourselves across the table and basically said, we're going to win this battle when we change the social norm around physical activity. So I think the tobacco analogy that came up a few minutes ago really is an apt one. I mean, in my lifetime, that issue's gone from it was cool to smoke, and every movie star smoked in every movie from start to finish, and it was smoking in the background and all of that, to if somebody lit up a cigarette in this place this morning, there'd be a riot, right? So it's changed 360 degrees, right, in our lifetimes. And with regard to the physical activity and diet issues that influence the obesity and other health outcomes, I think we've come part of the way. I think we've gone to the level of it's a good thing to be physically active, and it's a good thing to eat well. We haven't gotten to the point where it is socially unacceptable to be sedentary or to eat very poorly. And so the images that we see of the overweight guy on the couch with the pizza boxes laying all over the place and that sort of thing, we still snicker when we see that. And I think we'll know we will have won this battle when that's no longer funny. That's disgusting. It's sort of don't show me that. I don't want to see that. And I don't think of that as stigmatizing overweight. Whether we wanted to or not, we've already done that. Okay, that's out there. It's a sad thing, and it's unfortunate. So we don't have to stigmatize that outcome. It's the behaviors that produce it that we've got to stigmatize, and we're not there yet.
And it's a complicated issue as well, because as people say, you can tell people not to smoke, you can't tell people not to eat. First of all, you don't want to. I mean, we need food, and we don't want to completely exclude all of these delicious foods from our lives. We just need to eat them in moderation. The other side of the coin is that, yes, obesity stigmatization and discrimination is the one area in our world that is still acceptable these days. And as anyone knows, I've spoken to many obesity researchers. They say once you are overweight, it's really tough to reverse. It's really tough to then set the course in the opposite direction. So it really is about prevention. So what do you do with an overweight population that's having a hard time, really maybe can't reverse this, and will live the rest of their life overweight and trying to moderate their intake without making it into the kind of stigma that smoking is, because you're hurting, more than half of our population then. So anyway, I want to open it up to questions. I'm sure you guys have a ton of them. So, yep, right here. Do you have a microphone for? Oh, great. And maybe if you can also just introduce yourself with your name and your affiliation, that'd be great.
Hi, my name is Josh Rovner. I'm with the National Assembly on School-Based Healthcare. So I just wanted to thank Ms. Kennan for mentioning that that's one of the great things in the Affordable Care Act. And Dr. Rhee, I just wanted to correct you. That's actually $200 million, not $250 million. So if you have that extra $50 million laying around, we won't stop you from giving it to our clinics, because we'd love to see it. As we talk about solutions and what the next steps will be, I'm wondering what role the panel thinks the reauthorization of the Elementary and Secondary Education Act can be, and how maybe we can spend our Title I dollars to provide health care in school on prevention activities like this.
A component of that, I hope, will be the Fit Kids Act, which will be part of that reauthorization. At least I have my fingers crossed that it will be. And that act won't solve the whole problem, but it will require the schools to report on the quality and quantity of physical education and other physical activity-related services that they currently provide. Right now, no state really requires a serious accounting of the quality and quantity of physical activity-related services, including physical education that the schools are providing. And a starting point, I think, is to shine the light of day on that, so that fewer schools get away with the kind of services that Madeline described earlier. It doesn't have to be that way. Maybe a starting point is to get it out there in public view.
Another question?
Hi, I'm Teresa Johnson from Troy University in Alabama, where we certainly enjoy the obesity epidemic, and sadly in epidemic proportions in our part of the country. But one thing I haven't heard mentioned today is this question: how can we engage the food service industry, much like the sodium reduction initiatives that have been started across the country? How can we get them on board to help? Because I think if we could change some of the actual foods that are popular with children, it would be a step in the right direction as well.
Sure.
I've done a lot of reporting on the menu labeling issue, and the data, as many of you know, is mixed. And whenever there's a study saying it doesn't work, it seems to get a lot more publicity than the studies that say it does work. But the industry used to oppose that. I mean, they filed a suit against it. They fought it in the States. They came around and ended up supporting a compromise version. And they came around, and I talked to some people in the industry, and I talked to some people on the health side. And the industry came around, and I'm not saying this is going to solve the problem, but there's a glimmer of hope here. As consumers get information and begin demanding information, the industry starts responding and puts more healthy options out. It doesn't mean they're getting rid of every unhealthy option, but there are more healthy options. And when I went onto the National Restaurant Association website and I looked at trends coming, because it was just sort of cool, I stumbled across it, wasting time. Some of the trends that chefs were saying for restaurants to be cognizant of as they develop their menus, healthy side dishes for children was like one of the top 10. More fresh fruits and vegetables was sort of permeating all of their top ideas. Some of the really gargantuan caloric menus dropped from some fast food menus. The famous one was, what was it called? The fried, was it the onion? Some kind of, it had like 14,000 calories in one appetizer. It was some kind of fried blooming onion or something. And that sort of became, the fast food industry's equivalent of macaroni pizza, and they dropped it. So as information about what we were eating, because we eat a lot of our meals in fast food. So as information becomes available, as consumer demand changes, and there is some evidence that it will change, and it is changing in, like, the King County, Seattle area already has labeling. Will the industry start realizing that, forget their responsibility, their business interest is going to be creating some healthy foods? I think the recent controversy around what's in the fast food toy games, that's really a problem if you're a parent. No, you can't have the one with the toy. You can't have the soda, you can't have the French fries, We're on a highway, we have to have something that's not ideal to eat today, but I'm going to try to get you the healthiest thing, or I'm going to, try throwing out the really bad parts so your kid can keep the toy. I mean, that doesn't work either. So I see that as, think about it for smartphones or whatever else you have. You can actually get, there are apps now about what you're eating and what you're ordering and what the caloric content is. Now, that is not going to permeate our entire society. There are all sorts of disparity issues and cultural issues, and not just who has a smartphone, but who's going to use that app. But you can go through your day with your phone, eating even in not so healthy fast food outlets, and ending up with the knowledge to guide yourself through to a healthier diet. And I think there are signs the industry responds.
I also want to add that there are cultural issues that play here. I'm thinking in the African American community, we have generations of certain foods that we eat that is passed on from families to families to families. It's part of the tradition of being, you all have heard of soul food. And soul food is very fattening when we really think about what it is: fried chicken and greens with fat backs, et cetera. I mean, and that is part of our social and family fabric in a lot of the African American community. So to change that requires a paradigm shift, and it requires education. Bernadette was talking about the cognitive learning with the young children and in the schools. You have to start with the new generation and then work with the faith-based community to educate the older generation, because all of the research shows if you have an obese family, the likelihood of that young person being obese is skyrocketed. I think the research has shown it's over 50%. So you have to address those issues. Churches are a good place to address that. When there is community will within a community, we change things. And we cannot always legislate it, particularly when it comes to food, because it is part of what we need in order for us to continue to maintain. But we have to work with the community and the parents and educate kids on the best things. Outbacks does not serve the blooming onions anymore. because it has been educated in the community that it was like 1,500 calories or something. And so as a result, it's no longer in the menu. I was looking forward to ordering it recently. I asked for it, and they said we don't serve that anymore. And I had not had it in like 3 years, so I didn't know it was no longer there. But we have to teach people occasionally you can splurge. However, you have to do it in moderation.
Over here?
Hello?
Oh, I'm sorry. Sure.
Is it working? Okay. How you doing? My name is Yusuf Battle. I'm an exercise physiologist with a company called Fit Solution. But I'm also a liaison. I work with the Montgomery County Commission on Health, which is right next to Washington, D.C., for those that are not out of state. And also I'm on the Governor's Council of Physical Fitness for the state of Maryland. So I try to help all these individuals work to get some of the things done that you're talking about. I have a concern. I hear some of the positions, and I wanted to get some of your input because there's a program that American College of Sports Medicine created called Exercise is Medicine. And I wanted to hear more about how physicians are effectively using this, because this is something that I want to try to get used more in Montgomery County and in Maryland. But there are a lot of little idiosyncrasies and things that we have to get past to make it more effective. You know, the accountability with the physician. For those that don't know exercise is medicine, it provides accountability, more patient accountability with the physician and the patient about obesity and physical activity as a way to affect obesity. But I just wanted to put it out there and get ideas from you all about whether you know about the program or how it's being effectively used.
Are physicians writing prescriptions for exercise? Is
That's
that
the
part
goal of the program, to get them to include physical activity as a part of the prescription and to make it a part of a vital sign in every doctor's visit. So it will be addressed. So.
Anybody want to comment on that?
Just to say, I'll often write prescriptions, and I'll actually put it on a prescription pad, because that kind of adds to the fun and a little bit the mistake, and it formalizes it. Say, this you need to do. And I do that with kids who are depressed or have other issues, right? Or where there's obesity as a part of it. I don't know about this particular program, but I will make it a part of a prescription. I can't speak to this program.
Exercise is Medicine is a very important initiative aimed at enhancing the quality of the interaction between the physician and the patient with regard to physical activity. As it stands right now, we have a problem in this country with reimbursing physicians for preventive services. And I hope that the recent Health Care Act is going to move us in the right direction on all of that. But to try to be concise about it, Exercise is Medicine is aimed at establishing physical activity as a vital sign. You can either put quotes around vital sign or literally vital sign. It's sort of debated either way. We need to create a HEDIS measure around physical activity, and there are some large healthcare systems in the country that really are doing this now. Kaiser on the West Coast is one. We need to nationalize that. We need to make physical activity assessment and counseling and promotion in the healthcare setting a part of normal practice. But to do that, we're going to have to reimburse physicians for providing that service, and we're not very good at doing that right now.
It's so important. I think one thing you should be aware of, I know United Health now and CDC has been promoting this, has been the intervention for, pre-diabetics, generally overweight people who are close to getting diabetic, YMCA. Like there's actually a program at the YMCA that's been shown to be evidence-based. I think that might be something interesting, a certain program that actually addresses that. I do want a couple of quick comments. I think what businesses and employers do is so important, and we've been referring to that, and how we think about the healthy choice being the default choice. I think frequently the fries and soda is generally the default choice, and I know a lot of places, and we we're so happy that we're now smoke-free, finally. It took us a little while to figure that out. But government building, and we're now looking at our, the people who are providing food choices, how we can make the healthy choice the default choice, so that, you kind of have to ask for the fries. I mean, you kind of have to ask for the soda. It just comes with the water automatically. So I think thinking about that, I also think when I think about schools, I've heard about innovative programs, spaces that are not used at certain hours. How do we get programs so that those become spaces for physical activity? And because these are unused spaces oftentimes, and for the communities that oftentimes are looking for safe spaces to be physically active. So I think those types of programs are also very important to think about.
I think I had this one before.
My name is Pamela, and I'm a parent of a child with a mental health disorder. I wanted to compliment you, Ms. Black, on setting up safe places in schools. That's what we call them, where students can go when they need to check out or they need someone to talk to. We call them safe places. And my daughter's in high school, and there wasn't a safe place. I had to get my daughter hospitalized to get the diagnosis of anxiety disorder. So I didn't get help with the prevention. I had to wait until she imploded. Once I got the diagnosis, I was able to force the school to create a behavior intervention plan, and I personally set up and went and talked with the administration and people in the school to find a safe place and safe persons. So there are not a lot of parents out there that have the tenacity that I have. But how can we help the administration that doesn't have that spot that you were talking about to that level? How can we help create something or a safe spot for our children so that they can check out, and that whatever their mental health disorder is, they won't be stigmatized and they can actually go and chill and then re-enter into the school curriculum, mainstream or whatever. So I have this for my daughter. Every year we transition her out of school, and then before school starts we transition her back into school and also find the safe people in the safe places. But there should be a central location that's not stigmatized. How do we do that as parents to help the administration? Sure. Thank you.
I'd like to speak to that first, and I really, really support and applaud you for your advocacy for your daughter, because there are so many parents, like you mentioned, that don't feel comfortable enough to be that advocate that they need to be and feel very helpless. Exactly.
So whenever my daughter had a panic attack, I knew what would help. I knew what would help her chill or disconnect, as she says, versus me letting her fully implode and then having to have her hospitalized. That was too much. So everybody has a bad day and a bad moment, but she needs to know in school where her safe place is. How do we do that? How do we talk to the administration?
Yes.
Because like you said, there's no money.
Right.
Very little resources.
Yes. It took me 2.5 years to get into a school district in Arizona that would let me measure depression. Okay. Because, again, they didn't have support mechanisms. They would say, well, if we find it, what are we going to do with it? However, I will tell you what worked with me. It was data. It was the evidence on how mental health is connected to academic performance and kids staying in schools, because superintendents, schools get paid for seat time and for academic performance of their kids. So if we can show superintendents that mental health is linked to good functioning and academic performance in kids, that's what actually got me in the schools. Parents can use that data, parent groups, provider groups can use that data, but help them to understand those links are very evidence-based.
I totally agree. I think that educating teachers, administrators of the schools to really understand that good mental health enhance school performance. And if you are having youth that are having behavioral health issues, they are not going to learn well, or they'll stop coming to school. So I think that, again, it's the prevention component. And you also have to have the safe place in the school. And I think that at the national level, the education department needs to be talking to the Department of Mental Health, needs to be working with HRSA to really look at how do we integrate it and make it part of the fabric of America, that every school has a school safe place in it, from the elementary school to the middle school, and particularly at our high school level, when the prevalence of mental health really creeps its head. The other thing I also want to say in regards to obesity and mental health is that we have to start really upstream. We have a program in our Department of Mental Health called Healthy Start. And Healthy Start is gynecologists and primary care providers identifying depressed parents at the point of birth, or people associated with postpartum. You heard Dr. Pate talked about the fact that if children at 1, at 2, learn how to do physical activities from their parents, they're not interfacing with any system yet. At 4, at 5, we do have some preschool available now. However, it starts at home. And if we have depressed parents who won't cook, who gives French fries to children, who gives them chips and Pepsi for dinner at 3, we are starting the obesity issue. And therefore, you have to start upstream. We have a program for parents that comes in with their babies, and we provide psychiatric as well as counseling and supportive services and parenting group. And part of those parent group includes good eating. It includes talking about, you know, what to do with your child and to get them active so that you don't start yet another generation of children that are being impacted by learned an environment and, you know, enhancing their vulnerability for mental health issues. So we really have to do it at multiple prongs, not only when the child is becoming of age and understanding, but also when we identify it in the parents that are having the babies, because we know that children do what their parents do.
Just a quick comment, if I could also, when you see a parent like yourself who's developed maybe naturally this tenacity, this is golden. And what we found is so helpful is to hook a parent like yourself who's learned the hard way and help them teach other parents how to become agents of change in their system. So we've developed a national, if you will, parent empowerment.
You're being recruited right now.
Yeah. So we like to clone you. And so we take parents and we say, can you teach more parents? And we found that a real important way to spread the network.
Joe Boyce, George Washington University School of Public Health. I really am grateful I came today. It's really an informative forum. The last course I taught for the past couple of years at George Washington University is America's Health and National Security, that makes the point the Surgeon General was making, that we cannot continue, we cannot compete with the Chinese or any other country if we don't solve this problem. And I think there's an elephant in the room, or maybe an elephant in the country or in the world. Wilkinson and Pickett got a great deal, British epidemiologists got a great deal of press in the UK about the impact inequality has on health. And it's a tremendous impact. If anybody hasn't read their book, The Spirit, and there are a number of other books in this field, the UN has a report out on the same thing. But it shows as a country gets more and more equal, and they looked at 20 developing countries and all 50 of the United States, and they found in every case, the more unequal the society, the worse the health, the worse the obesity, the worse the mental health problems. They looked at all 50 states in America, and our 2 best states are New Hampshire and Vermont, because there is less inequality there in public health. But I think that's an elephant in the room. that we can't neglect, that we need to be aware of and to look at, because all the things we're doing, if this is a big factor, and it sure looks like it is, we need to address this one as well, and we need to come together as a people and address it. Thank you.
Hi, good morning. I'm Rosemary Chalk from the Institute of Medicine, and we've produced a number of reports that touch on and really support many of the views that you've expressed today, particularly in the area of childhood obesity. But we've done two other reports that I just want to highlight. Both came out in 2009. One is called The Prevention of Mental, Emotional, and Behavioral Disorders Among Young People, and it's a review, it's a systematic review of the evidence in support of prevention and early intervention programs. And again, it really reinforces the importance of noting the emergence of mental health disorders, in fact, early symptoms during adolescence, and the importance of prevention and mental health promotion, and tries to make the argument that these are really two separate streams that need attention. The importance of working with schools and education, the good behavior game, the triple P parenting interventions, and working closely with the schools. But the one point I want to underscore as well is we really lack a systematic national database in this area, and the panel speakers have pointed out the importance of data. But these studies have shown that we really don't have good national surveys of the prevalence of mental health disorders, nor do we have the capacity at present to really measure effectively the extent of preventive or mental health promotion activities. So I would just encourage you to really go back to your agencies and say, why don't we have this data? We've got great data about chronic disease, but this is one area where the mental health area is really lacking high-quality data.
I think those are all the questions that we have time for, but I just want to thank you for coming, and I want to call Bernadette up just to give some closing remarks.
This has been an outstanding panel, and I want to thank each of our esteemed guests for what not only their knowledge and skills in their areas, but what they're doing to promote the mental and physical health of children. Someone by the name of Helen Keller was asked, it must be so terrible to not have any eyesight. And she said, not any more terrible than to have eyesight, but no vision. Well, we have the vision. We have many innovative solutions for what needs to be done. Now it's time for execution. And I really didn't want this to be another panel where people get together, we talk, we put out a white paper, and nothing comes of it. So we have strategies now to follow up on this panel. We'll be writing a health policy brief that will be distributed to legislators. We are working and talking to funders to fuel more dollars into programs that are necessary to promote the mental and physical health care of children. And I applaud each one of you for what you are doing in these areas, because we know a healthy childhood is critical for a long, healthy adult life. Thank you for coming today.